Think about it. The human brain is literally the most heavily guarded fortress in your entire body, protected by the thick bone of the skull, wrapped up in tough layers of membranes, and secured by the highly restrictive blood-brain barrier. It's perfectly designed to keep out all microscopic invaders. But what exactly happens when those ultimate defenses fail? Today, in this explainer, we are stepping right into a high-stakes medical detective investigation. We're going to uncover exactly how microscopic pathogens breach this incredible fortress, look at the absolute chaos they cause once they get inside, and figure out how we can read the clues they leave behind to stop them before it's too late. Let's get started. Here is the roadmap for our investigation today. 1. The 3 CNS threats. 2. Breaching the fortress. 3. Prime pathogen suspects. 4. Reading the clinical signs. And finally, 5. Deadly complications. All right, part 1, the 3 CNS threats, identifying the crime. So picture this. A patient comes in with a fever, a splitting headache, and some major neurological changes. We have to ask ourselves, what actually happens when the brain's ultimate defenses fall? Our first job is to determine exactly what part of our fortress is under attack. Because these invaders, they don't just strike at random. They establish very different types of beachheads depending on where they land and what kind of pathogen they are. And that leads us to 3 distinct clinical emergencies. Our very first emergency is meningitis. I want you to think of the meninges, the pia, arachnoid, and dura mater, as the actual physical outer walls of our fortress. Meningitis is the inflammation of these specific walls, usually triggered by an underlying infectious bug. What you need to picture here is a diffuse, widespread inflammation stretching all the way across the outer layers of the brain. It's everywhere on the surface. Now, while meningitis attacks the outer walls, encephalitis is a direct strike right into the inner sanctuary. We're talking about inflammation of the actual brain parenchyma tissue itself. Unlike the widespread, diffuse nature of meningitis, encephalitis is often highly localized to specific lobes of the brain, and that's what causes those distinct neurological deficits. And yet, unfortunately, sometimes an aggressive invader causes both of these simultaneously. We call that dual threat a meningoencephalitis. And then we have the third threat, the brain abscess. If encephalitis is a direct strike, a brain abscess is basically an enemy camp built right inside the brain tissue. It usually starts off as cerebritis, which is just an early localized inflammation, but eventually it liquefies and forms this walled-off capsule filled with purulent or pus-like material. It's a highly localized, expanding mass that literally pushes into and destroys the surrounding brain tissue as it grows. Moving right along to section 2, breaching the fortress, routes of entry. Okay, so how on earth do these tiny microscopic invaders actually get past the highly guarded blood-brain barrier in the first place? Well, they're incredibly crafty. Our source material points out 4 primary routes. Route number 1 is hematogenous, basically using the bloodstream as a highway. Pathogens hanging out in the nasopharynx, the lungs, or on infected heart valves just seep into the blood and ride it straight into the cerebral circulation. Route 2 is contiguous spread. This is when an infection right next door, like a really severe frontal sinus infection or mastoiditis in the ear, literally eats through the nearby bone or travels up tiny emissary veins right into the brain. Then we have direct inoculation. This is a physical breach, think penetrating trauma, or neurosurgical procedures like placing a shunt, where non-sterile pathogens get a direct, VIP tunnel inside. But it's this final route that is arguably the most fascinating and terrifying. Pathogens can literally hijack your own nervous system. Viruses like herpes simplex use a crazy mechanism called retrograde axonal transport to travel back up your nerve fibers directly into the brain. And then, well, there's the stuff of literal nightmares. Naegleria fowleri, the brain-eating amoeba. Say someone uses a neti pot with unsterilized water, or they dive into a warm freshwater lake. The amoeba rushes up the nose, latches right onto the olfactory nerve, climbs straight through the porous cribriform plate at the top of the nasal cavity, and infiltrates the central nervous system. It causes a highly fatal meningoencephalitis. Absolutely terrifying, right? Which brings us to part 3, prime pathogen suspects, the usual suspects. All right, we know how they get in. Now we've got to profile the actual invaders. Connecting a patient's risk factors to the correct bug, that is the ultimate key to choosing the right life-saving antibiotics. Let's look at our suspect lineup. For acute bacterial meningitis, Streptococcus pneumoniae is your prime suspect. It's the most common cause, especially after a respiratory infection or in patients who don't have a functioning spleen. But if you have a patient living in super crowded conditions, think college dorms or military barracks, your suspect quickly shifts to Neisseria meningitis, which spreads through respiratory droplets. Then we have Listeria monocytogenes. This bug sneaks in through unpasteurized cheeses and deli meats, and it specifically targets patients over 50, the immunocompromised, and pregnant women. For brain abscesses, if you're looking at a scan and see multiple lesions, you have to suspect a blood-borne shower of bacteria. That heavily implicates Staph aureus, specifically MRSA, often coming from infected heart valves. And if you see non-pyogenic lesions right in the basal ganglia of an AIDS patient with a CD4 count under 100, toxoplasmosis is your primary culprit there. But listen, out of all these suspects, there is one virus that demands immediate recognition: HSV1. It's the most common cause of encephalitis, and it has this incredibly scary predilection for the temporal lobes of the brain. If this goes untreated, it carries an exceptionally high mortality rate of 55 to 70%. No joke. This is exactly why the absolute second you even suspect HSV1 encephalitis, you have to administer the antiviral drug acyclovir. Time is brain tissue, guys. Let's dive into part 4, reading the clinical signs, the bedside evidence. So how do we actually spot these specific attacks just by looking at our patient at the bedside? Well, we divide our clues into meningeal signs and cortical signs. Pure meningitis causes meningisms. That means fever, a severe headache, and nuchal rigidity, which is a profound stiffness of the neck. When you bend their neck forward, those inflamed meninges stretch, and it causes excruciating pain. But what if your patient has a headache and fever plus some totally new behavioral changes, or severe memory impairment, aphasia, or even seizures? Those are cortical signs. That tells you the cortex, the actual brain tissue itself, is damaged. And that completely shifts your diagnosis away from pure meningitis and straight toward encephalitis or brain abscess. Now, if you've been around the words, you know medical textbooks famously teach 2 physical maneuvers to check for meningitis: the Brudzinski sign, where bending the neck involuntarily flexes the hips and knees, and the Koenig sign, where extending the knee at a 90-degree hip angle causes severe pain. But here is a massive clinical pitfall. These classic tests are incredibly insensitive. We're talking only about a 5% sensitivity rate. So a negative result on these tests absolutely, categorically does not rule out meningitis. But don't worry, because there is another bedside maneuver that boasts a sensitivity of nearly 100%. It's called the jolt accentuation maneuver. It's super simple. You just have the patient rotate their head horizontally back and forth about 2 to 3 times per second. If that rapid movement acutely makes their headache worse, that is a highly reliable positive sign of meningeal irritation. It's fast, it's simple, and it's a far more accurate tool for your bedside investigation. This leads us to our final section, part 5, deadly complications, the aftermath. Because look, identifying the infection is really just half the battle. The aftermath, it can be just as deadly. If we don't jump in fast, these pathogens trigger physiological cascades that can literally kill the patient faster than the initial infection itself. One massive complication is communicating hydrocephalus. Picture the subarachnoid rod space filled with cerebrospinal fluid, or CSF. Now, that fluid is supposed to drain out through these tiny valves called arachnoid villi. But the bacterial infection physically clogs up these villi with inflammatory debris. Suddenly, the CSF has nowhere to go. Back pressure builds up rapidly, causing the brain's inner ventricles to balloon outward. This soaring intracranial pressure literally crushes the brain from the inside out. It leads to severe nausea, papilledema, which is swelling of the optic nerve, and palsies in the 6th cranial nerve. That paralyzes horizontal eye movement, causing horrible double vision. But the absolute worst systemic horror show? That comes from the endotoxins released by Neisseria meningitis. These toxins trigger a massive explosion of pro-inflammatory cytokines. This puts the entire body's coagulation cascade into extreme overdrive. The body starts rapidly forming microscopic blood clots, microthrombi, in blood vessels everywhere. And because it's making so many clots all at once, it burns right through all of its clotting proteins and platelets. This causes a terrifying paradox called disseminated intravascular coagulation, or DIC. The patient is massively clotting, yet simultaneously bleeding out, because they literally have no clotting factors left to stop a bleed. Combine that with massive vasodilation from the endotoxins, which causes the systemic blood pressure to just absolutely crash, and the patient falls into irreversible septic shock. Central nervous system infections are literally the ultimate race against the clock. We've mapped out how the fortress gets breached, profiled our microscopic suspects, and looked at the devastating aftermath of their attacks. The clues are all right there, in the imaging, in the patient's history, and in those bedside symptoms. So the real question is, the next time you look at the evidence, are you prepared to connect the clues and stop the invader before the fortress falls? Keep that detective mindset sharp, and I'll catch you in the next explainer.